Welcome to the scariest room in the hospital, the resuscitation bay. Let's break it down. Despite seeming like chaos, it's actually very strict choreography, and it takes about 100 people knowing their role perfectly to make it work. As the doctor, you are the maestro to the orchestra, and you need to know the algorithm perfectly. The principle is A, B, C, D, E, and it's the same every time to optimize synchronization and not miss anything. We work down the system, assessing and stabilizing as we go, and every time the patient decompensates, we go right back to the top and start over. So A is for airway. You're looking to see, can they talk? Do they have stridor? Are they gurgling? Is there facial trauma? Are they a GCS less than 8? And always assume a C-spine injury and place a C collar. How do we manage this? So jaw thrust, suction, and OPA or NPA, you might have to intubate, right? Do RSI with C-spine precautions and have backup plans like a bougie, video laryngoscopy, or a surgical airway if you need. And always remember, an agitated trauma patient is usually hypoxic, hypercarbic, or hypotensive. They're not just acting out. So fix the physiology, not the behavior. If you're thinking about agitation meds, intubate instead. B is for breathing. So inspect chest rise, auscultate, percuss, look at their SpO2 and their work of breathing. These patients may need a chest tube for a pneumothorax or a hemothorax, or an occlusive dressing for an open pneumo. For chest tubes, you're going at the 4th or 5th space and the anterior axillary line. And also, these patients might be hypotensive with absent breath sounds on one side. Think about attention pneumothorax here, and they'll need a needle decompression in the second intercostal space. C is for circulation. So get pulses in all of their extremities, femoral pulses, look at their blood pressure, look at their skin signs or any obvious signs of external bleeding. And how do we manage this? So patients obviously bleeding, we need direct pressure. You might need a tourniquet or a pelvic binder. You're stopping the bleed here. You also need 2 large bore IVs or a cordis introducer for central access in the femoral, subclavian, or IJ. All major trauma patients get blood, not liters of crystalloids. So anytime they're hypotensive or there's a circulation issue, blood is your answer. Assume all patients are bleeding. So replacing with crystalloids dilutes the remaining cells trying to carry oxygen, and clotting factors trying to stop the bleed, creating a coagulopathy. The best place for a cordis in a trauma is the fem line. You have fast access, you're not in the way of anything going on up here, and that way you can give mass transfusion protocol if you need it. And on that note, a cordis is not a triple lumen. It's a large bore, usually 8 to 9.5 French, straight short catheter that optimizes flow for rapid or mass transfusion. There are 5 places you can bleed out in trauma: chest, abdomen, pelvis, femurs, and floor. So the chest holds about 1 to 2 liters, the abdomen can hold up to 5 liters, the pelvis can hold up to 2 to 4 liters, and each femur can hold 1 to 1.5 liters. The floor, you can bleed out anywhere, right? You can exsanguinate to death. D is for disability, so a quick neuro exam. So get your GCS, your pupils, any lateralizing signs. You can think about mannitol or hypertonic saline, but really we're just trying to protect brain perfusion, so we don't want the hypotension or the hypoxia. And you want a quick neuro exam to see if maybe there's a TBI or signs of something that caused the trauma, like a stroke. E is for exposure and environment. So fully expose this patient and inspect front and roll them to their back, a log roll. And how do we manage this? So anything bleeding that we missed, any broken bones that need to be reduced and splinted, and then keep them warm, right? Warm blankets, a bear hugger, because the lethal triad can also kill this patient.